Good morning, all. I think uh, uh, some of you have not activated the audio, so please activate so that you can interact actively. Uh, so, if any problem, please message me on my mobile number, or you can send message here also in chat. So today we are going to discuss the poor responder. This is one of the very burning problem in IVF treatment. One is diminished ovarian reserve, that is poor responder, and another is thin endometrium. Because for any successful IVF treatment, there are only three things which are most important. One, the quality and quantity of the gamete. Second, endometrium. And third, a transfer technique. Transfer. So these are very important receptivity of the endometrium. These are very important aspect of the successful IVF treatment. So one of those aspects, thin endometrium, we have already discussed. Today we are going to discuss poor responder. The data from large unequivocally show that the IVF success is depending on both the number of the oocytes retrieved and woman's age. That means quality and quantity, both are important. The quality is decided by women's age, and quantity is decided by what is a pool of the primordial follicles left. Based on pool of primordial follicles left, there is a recruitment of the cohort of the follicle, and that gives rough idea about the ovarian reserve. Of course, those follicles which are seen in sonography, most of those follicles, they do not have a developmental potential. Some of them may be in the stage of atresia. So, but you can say 65% to 70% follicle, what you see on your scan on for follicle count, they have got development potential. So you can bank upon those follicles. Now, what do you mean by poor response in IVF stimulation? What I mean to say, you are stimulating the patient, and during the stimulation or after completion of the stimulation, when you will label that, okay, this is a poor response. The meaning of the poor response is if the stimulation is lasting more than 12 days. The exception is PCOS. In PCOS, sometimes the stimulation lasts more than 12 days, 13 days, 14 days, without compromising the quality of embryos and eggs. Otherwise, except PCOS, if the stimulation lasts more than 12 days, it alerts you about the poor response. Another criteria is if the gonadotropin consumption is more than 4,500 units in whole stimulation, then it should alert you that it is a poor response. The peak E2 on the day of trigger is less than 800 picogram, or on stimulation day 5, if it is less than 100 picogram, then also it is because of the poor response. Normally speaking, any mature follicle is responsible for 200 picogram of estradiol level, which is secreted. So if the peak E2 is less than 800, that means less than 3 follicles are there. So it is said to be a poor response. Even after retrieval, you are getting less than 5 oocytes, then it is called a poor response. So these are the criteria uh, which can help you in labeling your IVF response as a poor response. Because many times from the beginning you do not know whether it is a pakka poor responder or it is a normal responder. Based on your routine testing, you might label it as a normal responder, but then while stimulation, you come to know that no, it is a poor responder. I would like to add one more thing to this is when there is asymmetrical follicular growth. What do you mean by asymmetrical follicular growth? When the lead follicle is 4 millimeter or more ahead of the rest of the average cohort, then it is called asymmetrical follicular growth. So when there is a asymmetrical follicular growth, it is again a sign of poor response. Now, how do hyporesponders differ from classic poor responder? We all know classic poor responder right from the beginning. We know they have got diminished ovarian reserve, their age is advanced, and they have history of poor response before. So we know what are the classic poor responders. But what about the hyporesponders? Hyporesponders are unexpected poor response. From a clinical perspective, the hyporesponders represent a patient category that differs from both normal responder and classic poor ovarian responder. The hyporesponder is a patient with a normal ovarian reserve. Important thing to note, they have got normal ovarian reserve. And they show unexpected, suboptimal, or poor response to your ovarian stimulation. It is usually manifested by a low follicular output rate, that is called FORT. Now, this terminology is very important because ultimately it is proved that more number of the follicles. What do you mean by follicle output rate? Suppose you have got 10 antral follicles, and if the 6 follicles are developing, then it is called 60% follicle output rate. The higher the follicular output rate, it is because of the better stimulation, and they are likely to give at least decent number of euploid embryos. So follicle output rate is very important, and ultimately that should be your aim while stimulating. But at the same time, one should not forget that to get the best follicle output rate, you should not bombard the patient with very higher dose of gonadotropin, like 600, 700, 750, because that we will discuss little later, it has got its own adverse side effect. And apart from that, if you give too much higher dose of gonadotropin, you might get a little better follicle output rate. But the follicles which are coming up extra, they are harboring a resistant oocyte, and those oocytes are less likely to give the pregnancy rate. So you should give the optimum quantity of the gonadotropin, which gives a optimum follicle output. And these hyporesponders, they use of increase total dose of gonadotropin, and they give lower than expected number of the oocytes retrieved. Now, the management of the hypo responders might be associated with the increased treatment cost, decreased cumulative live birth rate, and increased time to live birth. Now, until now, none of the poor responder criteria have taken into account this group of hypo responders to ovarian stimulation. We all were experiencing that there are two types of the patient poor responder we get into the practice. One, we have already anticipated, okay, these patients are likely to be a poor responder, and another, unexpected hypo responder. So you can label hypo responder as a unexpected poor responder. Why there is a poor response to stimulation? We try to understand. We are giving the gonadotropin, still the response is poor and the follicles are not coming up. It may be because of the reduced number of FSH responsive follicles due to reduced primordial follicles pool. Because ultimately enter follicle count directly represents the primordial follicular pool. So if the enter follicle count is less, it definitely gives evidence that patient has got reduced primordial follicle pool. Another reason, less than optimum starting dose of FSH. Now, if the calculated starting dose of gonadotropin is 225, and suppose if you start stimulation with 75, the follicle which are having low FSH threshold will start developing, but those follicles who are having a little higher FSH threshold, which they are harboring a absolutely normal oocyte, they are not going to come up. So that's the reason that one should individualize the starting dose, and that is very, very important. In many of the studies, either they suggest to give fixed 150, fixed 225 units of the gonadotropin, which is not ideal. If you really want to optimize your stimulation, you have to give optimum dose of gonadotropin, not less, not more, because ultimately the cumulative success rate of your IVF treatment is directly depending on how many number of the oocytes you have retrieved. The third mechanism of the poor response is, and which is nowadays considered very important, is FSH and LH receptors polymorphism. If FSH and LH receptor polymorphism is there, this patient require higher dose of FSH and LH, or in spite of giving higher dose, they result poor yield. So these are the possible mechanism of poor response, why there is a poor response. Now let us think, what do you mean by diminished ovarian reserve? Whom do you consider diminished ovarian reserve? One should not get confused between poor ovarian responder and diminished ovarian reserve. There are many reasons for poor ovarian responder, and diminished ovarian reserve is one of the reasons for poor responder. So please do not confuse between the terminology. Now, what do you mean by diminished ovarian reserve? When the basal FSH level is more than 1200 international unit. Some of the studies have shown that anytime if you measure FSH and if it is less than 9.5 or crossing 10, even once also, and second time if you measure, if it comes to 7. But if you have notified basal FSH level anytime during her reproductive life more than 10, this patient is likely to be having a diminished ovarian reserve, even though antral follicle count may look normal or nearly normal. Second is antral follicle count less than 6. Third, AMH less than 1.1. Now, antral follicle count gives idea about the stimulation potential, and AMH gives idea about how your response to the stimulation is going to be, and to certain extent it gives some idea about the quality of the oocyte also. So if you compare AFC and AMH, if it is a normal responder, both carries equal weightage. But if it is a poor responder, then AMH is carrying more marks as compared to antral follicle count. What are the risk factors for anticipated poor response? Why there is a poor response? We understood what are the mechanism of poor response. Now we are thinking on what are the risk factors for anticipated poor response. These are the risk factors for poor response. One is short menstrual cycle length. In my practice, invariably, any young patient who is having a shorter menstrual cycle, which was not there previously, 90% of the time, if you measure the AMH is never more than 1.5, it is less than 1.5 only, which is very important clinical criteria to alert yourself about the poor ovarian response. One is short menstrual cycle. Now, why there is a short menstrual cycle? Because it is because of the shorter follicular phase. Why there is a shorter follicular phase? Because there is a late luteal rise of FSH, and which recruits follicle before patient starts menstruation. So by the time of day 2 or day 3, the follicle has reached to 9 millimeter, 10 millimeter, 11 millimeter. So there is a shortened follicular phase. Now, why there is a late luteal FSH rise in impending poor responder? Because of the lesser follicular pull. Because of the lesser follicular pull, there is less of inhibin A and B, which is secreted, and because of that, the inhibitory action on FSH secretion goes away. So there is a more of FSH secreted, and which is responsible for all this. Second is single ovary. Dr. Jogesh wanted to ask something. I think you have put off your microphone. Dr. Jogesh Bachao, you wanted to say something. Okay, fine. So another is a single ovary. Only previous, because of the previous ovarian cystectomy. Obviously, So single ovary. For the obvious reason, if the ovary is single, the ovarian reserve is less. And single ovary maybe because of the congenital or maybe previous ovarian uh, cystectomy has been done. The third reason is chronic smokers. The chronic smokers, they have progressive follicular depletion. Apoptosis is more. So in this, the ovarian reserve gets decreased. In all cases of unexplained infertility, you should definitely screen for AMH, even though your enteral follicle count looks normal or nearly normal. Because sometimes, even if the enteral follicle count is nearly normal, the AMH may be less in unexplained infertility, and that could be the reason for the infertility. The patient who have got previously chemotherapy and radiotherapy taken, they have got almost irreversible, especially if radiotherapy has been taken. Chemotherapy, in some of the chemotherapy, after 1 year, 1.5 years, uh, probably some reversal may be there. But if the radiotherapy is already taken, there is a fibrosis in the ovary, and because of that, the ovarian reserve is decreased. Important thing I wanted to tell you is a genital tuberculosis. We get a lot of patients in India who has who have history of genital tuberculosis in childhood. They have been operated for some laparotomy has done, some intestinal obstruction or some problem, and just they forget. Now, if we elicit the history, if the genital tuberculosis or abdominal tuberculosis, there is a history, these patients are likely to be suffered from tubal infertility, thin endometrium, as well as the diminished ovarian reserve. Because there is a close association between genital tuberculosis and because genital tuberculosis has got anti-gonadotrophic effect, it depletes the oocyte, and definitely the diminished ovarian reserve can be there. Apart from that, the less important reason is uterine artery embolization of the fibroid, those who have done. Another important thing to be noticed, the Indian woman undergoing IVF, the ovarian aging was found to be approximately 6 years older. I always tell this fact to all my patients. And practically, I'm sure we all are experiencing that more and more young girls, they just come for a regular checkup. They are not having child since 2 years. They are married since 2 years. Their age is 28, 26. And when we look into transvaginal sonography and look into enteral follicle count, the enteral follicle count is 6, 7, 8, 9. That's it. So, there is definitely the Indian woman has got start depleting follicles quite early, 6 years earlier than their Caucasian, their European partner. They start depleting follicle after 30 years. And the same thing happens here in after 20, 25 years. So this is two things are very important to point out. One, short menstrual cycle length. Two, unexplained infertility. Third, genital tuberculosis. And fourth, the Indian woman ethnicity itself is responsible for poor response. Now there are genetic risk factors certain. Those patients who have family history of premature menopause, I always ask whenever any patient they have got diminished ovarian reserve, always ask that what is the age of menopause when her mother got the menopause. So if they can recollect, you can correlate most of the patient mothers have early menopause. Another thing is fragile X mental retardation, that is FMR1 receptor problem. The FSH receptor polymorphism we already already discussed the important cause of unexplained poor ovarian response to a young woman. Now, important question, when we stimulate the patient, if there is a poor response once, that means next cycle also to be a poor response. This is a very important question asked by the patient. The answer is 40% of the time, the subsequent response to a second cycle stimulation is normal when the first cycle response was poor. So it is not necessary, you should not lose hope. If everything is looking reasonably okay, you should definitely try a second time, having standard protocol if it is suggested, and you are 40% of the time likely to get a reasonable response, even though first response was poor. Now let us come to, we have to define the criteria to label a poor responder. So in the literature, everybody has agreed that in IVF population, the quantum of the poor responder is between 4 to 27%. That is fine. Probably in Indian scenario, a little more. That is fine. But then how to label? Because if we want to publish the study, if we want to, compare any of the strategy, we should have a uniform criteria to label poor responder. So there are more than 42 definitions in various literature. But of late, since last many years, we have been following the Bologna criteria. We have been following the Bologna criteria. Now, what is the Bologna criteria? The Bologna criteria for expected poor responder is 1, the advanced maternal age, that is more than 40 years, or other risk factors of poor responder, which we have already discussed. Criteria number 2, the previous poor ovarian response. We have already discussed what is a meaning of poor ovarian response. Third criteria, the abnormal ovarian reserve testing. Accepted less than 5 to 7 follicle or AMH 0.5 to 1.1 nanogram range. So any two of these are present, then that patient, as per the Bologna criteria, should be labeled as expected poor responder. But if none, there is nothing, everything is normal, still patient has history of 2 episodes of poor ovarian response, even if he doesn't fit into any criteria, still that patient has to be labeled as expected poor responder. So this was about Bologna criteria, which we all know and we practice according to Bologna criteria only. But there are certain problems with the Bologna criteria, which we are going to discuss. The another criteria is the POSEIDON classification, that is patient-oriented segregation. There are 4 groups in POSEIDON classification. Group 1 and 2, they are, you can say, unexpected hypo responder. Group 1 and 2, they have got normal ovarian reserve. And group 3 and 4, they have diminished ovarian reserve. So in other words, they are expected poor responder. Group 1 and 2 are not expected poor responder, but group 3 and 4 are expected poor responder. Now, what is the difference between group 1 and 2? In group 1, the patients are young. The cutoff age they have kept is 35 years. With sufficient pre-stimulation ovarian reserve parameter, that is interfollicle count 5 and more than 5, AMH more than 1.2, and oocytes retrieved are less than 9 and with an unexpected poor or suboptimal ovarian response. So, in spite of young age, normal ovarian reserve, the oocytes retrieved are less than 9. So, group 1 can be classified only once we stimulate the patient. Then and then we can categorize group 1 and group 2. In group 2, the only difference is the patients are older, more than 35 years. The rest, everything is same. In group 3, the patient's age is less than 35 years, younger patient with already already known poor ovarian reserve, pre-stimulation parameter, that is antral follicle count less than 5, AMH less than 1.2, and we have retrieved less than 5 oocytes. In group 4, the patients are elderly, more than 35 years age, with diminished ovarian reserve. These are the true poor responder, difficult to stimulate, having the least success rate, elderly patient, diminished ovarian reserve, and oocytes retrieved less than 5. Now they have subgroup classification. Group 1 and 2 were further divided into 2 subcategories. The reason we are going to discuss little later. In subgroup 1A and 2A, they comprise of the patients with less than 4 oocytes retrieved. And subgroup 1B and 2B included the women who had 4 to 9 oocytes after ovarian stimulation. So this was, pictorial classification. That group 1 and 3 younger patients, group 3 and 4 elderly patients. Group 1 and 2 have got normal ovarian reserve, group 3 and 4 have got poor ovarian reserve. So in other words, the POSEIDON criteria are based on age, ovarian biomarkers, and number of the oocytes retrieved in the previous stimulation cycle. What are the deficiencies in using Bologna criteria? Why we are now looking into a POSEIDON classification? So there are certain problems. There are certain problems with the using Bologna criteria. So they had to rethink and classification of the poor responders. So what were the deficiencies? The deficiencies of Bologna criteria, it was not differentiating between young diminished ovarian reserve with 1 poor ovarian response, young normal ovarian reserve 2 times poor response, elderly diminished ovarian reserve, and elderly good ovarian reserve previous poor response. In short, these are the different sets of the patient. Their strategy for the stimulation may be different little bit, not 100%. Still, they are grouped together. It does not count age-related decline in the success rate with the same number of the retrieved oocytes. This is very, very important. The patients aged more than 35 were retrieving 8 oocytes and age less than 35 retrieving 8 oocytes. The success rate is bound to be more when the age is younger because the chances of number of the aneuploidy oocytes are less. So Bologna criteria was not counting. It was counting age as cutoff 40, and which was quite little high as compared. Practically speaking, it was that cutoff was quite high. Second, it does not count the varied response to the gonadotropin due to LH and FSH receptor polymorphism. Means In Bologna criteria, unexpected poor responder, they are not counted only because of the LH and FSH receptor polymorphism. So this was the major deficiencies. Apart from that, there are different live birth rate reported for Bologna poor ovarian responder aged. Just now I told you that if the age is less than 35, the live birth rate is 12%. But if age is between 36 to 39, it is 8%. If the age is more than 40, it is 6%. But Bologna criteria does not differentiate this. If the age is less than 40 years, it is considered as one of the criteria, and which is not true based on the evidence. Second, the implantation rates range from 15.3 to 29.4% in patients under 55 years age. By contrast, it ranges from 6.3 to 24.1% patient more than 35 years of age. So, if the patient is elderly, the implantation rate also decreases. Bologna criteria doesn't count that. Third thing, the ranges of 5 to 7 for enteral follicle, which is surprisingly if you keep some criteria, it has to be kept as a cutoff, not ranging between 5 to 7. What is the meaning of 5? 5 to 7. It has to be kept the certain fixed figure. And similarly, true with the range of AMH cutoff, that is ranging between 0.5 to 1.1. There is a lot of difference between stimulation profile, AFC profile, when the AMH is 0.5 and AMH is 1.1. The response to the stimulation is entirely different. So this range, which were suggested in Bologna criteria for AMH, was quite wide and which was not acceptable. So that's the reason these were the deficiency of Bologna criteria. Then what are the advantages of POSEIDON classification and why it is more useful? The full form of POSEIDON is patient-oriented strategies encompassing individualized oocyte number. The POSEIDON criteria strictly believes in number of the oocytes. The POSEIDON criteria believes that, okay, you cannot do anything to change the quality of the oocyte, but definitely you can do something to change the number of the oocytes. So whenever you are treating your poor responder, your mind should be absolutely diverted to increasing the number of the oocytes. Recruitment of the follicles should be more. There should be more follicle output rate. Then you get a better success rate, because every one oocyte give additional 25% success rate, but that will come little later. So the POSEIDON stratification distinguishes between good ovarian reserve patients who unexpectedly respond poorly to the exogenous stimulation, that group 1. We are talking about group 1. And the poor ovarian reserve patients for whom the response to stimulation will be invariably poor, like group 3 and group 4. It has given importance to related decline in embryo quality due to increase in oocyte NFUD rate. It has considered the importance of high gonadotropin dose to take care of FSH and LH receptor polymorphism. It has given idea about poor outcome when yield is lesser. And it has thrown light on minimum number of the oocytes required to get single euploid blastocyst. This is very important because it has been seen that one euploid blastocyst, if you transfer, the implantation rate is almost same in all age group, nearly same. because also, in other words, provided the endometrial receptivity is good, the implantation depends on majorly on the quality of the embryos. So your more the follicle output rate, more the number of the euploid blastocysts you are likely to get. This is what POSEIDON criteria aims to. Then the question comes, why the oocytes are abnormal with increasing age? We are talking so much about the effect of age on oocyte quality. Why they are abnormal? What are the mechanisms? There is increased aneuploidy with the increasing the age. That may be because of the mitochondrial dysfunction, because aging mitochondria. And that's the reason a lot of people talking about cytoplasmic transfer, because it changes the mitochondria. Second reason is granulosa apoptosis. Aging oocyte granulosa cells are more apoptotic. And third is the oxidative stress is more in aging oocyte. So this different mechanism responsible for increased aneuploidy rate in the aging oocyte. Now, is anything can be done for delaying follicle aging? Truly speaking, nothing much can be done. But still, there are certain studies which says that regular running, it reduces the hormonal stress and it enhances the Mg scavenger system. It might help in delaying the oocyte aging. And second is green tea. I always tell my patients, all IVF patients, to have a lot of green tea. So green tea, aminoguanidine, metformin, benfotiamide, potiamine, and pyridoxine. These are the some of the clinically proven molecule which should be added to your poor responder treatment regime, which might delay the follicular aging. So in group 3, who are just I wanted to highlight that in group 3 and group 4, who are definitely expected poor responder, the number of oocytes, as we discussed little earlier, matters. How many oocytes required? In group 3, average 4 to 7 oocytes are needed to obtain one euploid blastocyst. Whereas in group 4, that is elderly patient, at least 12 oocytes are needed to obtain one euploid blastocyst because of the higher aneuploidy rate in elderly women. But if we can somehow increase the quantity of the oocytes by chain of stimulation and accumulation, probably we can deliver the same result and clinical pregnancy rate in even elderly patients also. But then the total treatment duration increases. If patient is willing for that, definitely they should not be denied of treatment with their self eggs rather than advising rampantly for donor eggs. Now, these are some of the studies which shows the importance of number of the retrieved oocytes. Now, if you observe, this table shows the A.R.T outcome between group 1, group 2 subgroup and group 3 and group 4 co-responder. Now, if you look at the clinical pregnancy rate, in subgroup 1A, 1B, 2A, 2B, group 3 and group 4, the clinical pregnancy rate is same in subgroup 1A, subgroup 2A, group 3, and group 4. Now, these 4 groups are different. Age-wise also different. Ovarian reserve-wise also they are different. But since the oocytes retrieved were less, because in subgroup 1A and 2A, less than 5 oocytes are retrieved. So their success rate is same with the elderly who are bound to be a poor responder. What I mean to say, and what this study meant to say, is number of the oocytes are very, very important, because if number of the oocytes are more, it can compensate to a certain extent the quality of the oocytes also. Then coming to the effect of another the table which shows IVF pregnancy outcome according to the age of patient per cycle. Now, if you look at the clinical pregnancy, if the maternal age is less than 35 years, the pregnancy rate is 24%. If it is 42 years, 7.7%, 43, 5.4%, 44, 1.9%, and 45, 0%. It is Western data. So, after 35 years, the pregnancy rates drastically start declining. In Indian scenario, after really difficult to get pregnancy after 40 years, the isolated case may be there. I don't deny. Even it has happened with us also. That's different thing. But more or less, overall speaking, after 40 years, it's difficult, really difficult. You should advise them after one stimulation, trying for one stimulation, you should advise for a donor oocyte. And delivery rate, same way, delivery rate also declines because of the increased miscarriage rate in advanced maternal age. This is very popular curve, the effect of age on the oocyte. Now, the dark black line is suggestive of number of the follicles, and interrupted line is suggestive of proportion of poor quality oocytes. The number of the follicles, as you see here, it starts declining after 30 years of age. It is, and probably after 25 years starts declining. And similarly, the proportion of the poor quality oocytes starts increasing after that. So both goes hand in hand. There is similar decline, and here there is a similar increase. Now, this is an interesting finding, the AMH and numbers of retrieval for euploid embryo. Here on the left side is the AMH level, and downside is the number of the retrieval required. So if you look at the AMH level, higher the AMH level, less the retrieval, less number of the retrieval is required. And if the AMH level is less, the higher number of the retrievals are required. As I discussed earlier, if the patient is willing, financially sound, you should not lose hope. You can apply all possible strategies while IVF stimulation of the poor responder. You might require more retrieval, but ultimately you can achieve your goal. This is another interesting study, the effect of age with low and normal AMH on the number of the blastocysts. Now, red is suggestive younger age and blue is suggestive of elderly patient. Left side, there is a less than 1 AMH level, and right side AMH level is more than between 1 to 4. Now, if you look at the first table, first this thing graph, first part of the graph, the AMH level is, if it is less than poor responder, in poor responder, the number of blasts are literally half, between the, it is literally half if the age is more than 35. Whereas the same is not true when the AMH level is between 1 to 4. Second point to be noted, if the AMH is less than 1, number of the oocytes are blastocysts are less, whereas if it is between 1 to 4, number of the blastocysts are more in both age groups, younger as well as the older elderly group. So definitely AMH plays an important role in predicting number of the euploid blastocysts. Now let us look at the miscarriage rate at the different age group, age and AMH group. The first part is less than 33 years, second is 34 to 36 years, third is more than 37 years. Now there are three AMH groups. The white is very low AMH, gray is intermediate, and black is high AMH level. Now as the age increases, the miscarriage rate increases. After 36 years, it increases little bit, but definitely it increases. Second thing, if there is an intermediate AMH, that means 1.6 to 5.6, up to 36 years of age, the miscarriage rate is not of much difference, but after 36 years age, it increases tremendously. And third point to be noted is when the AMH is high, in all age groups, the miscarriage rate difference is not too high. If it is less than 33, between 34 to 36, or more than 37 years of age. Now, how many oocytes needed to have one euploid blastocyst? We already discussed. The younger group 3 needs 4 to 7 oocytes, and older group needs 12 oocytes. So your ultimate aim should be to collect this many number of the oocytes to get at least one euploid blastocyst, and which gives equal pregnancy rate across all the spectrums of the age group. Now, what are the different strategies which can be adapted while treating the poor response? So, one is commonest is the gonadotropin dose increment. It has been seen that results do not improve with the increasing dose beyond 300 international units. But this studies was with recombinant FSH, and it is our practical experience. Then the efficacy, stimulatory potential of 300 international unit of recombinant FSH is higher than equivalent dose of HMG. This is practically what we all have experienced. So I would consider 450 HMG as cutoff. I would not give HMG more than 450 and recombinant FSH more than 300. Now, if you look at the graph, this very graph, which is the dark line is suggestive of standard dose, and dotted line is suggestive of increased dose, and there is hardly any difference in the live birth rate. So that itself says that beyond certain limit, there is no role of increasing the gonadotropin dose to increase live birth. You might get more retrieval of the more oocytes, but those extra oocytes harbor and extra follicles harbor a resistant oocytes, and which are not likely to give the pregnancy. What happens? The FSH induces the expression and secretion of FSH binding inhibitor from granulosa cells, and this inhibitory peptide blocks the binding of FSH to its receptor. Therefore, The administering excessive dose of exogenous FSH may increase the production of FSH binding inhibitor and other local inhibitory factors which suppress the follicular growth and development. So there is no role, and one should try to avoid using extraordinary high dose of gonadotropin. This was a study comparing HMG or recombinant RFSH plus recombinant LH. And what they observed, they compare between enter follicle count less than 4, 4 to 6, and 7 to 10. And what they observe that the clinical pregnancy is if the enter follicle count is less than 4, it is 16.5% in RFSH LH group, whereas only 3.5% in HMG group. In 4 to 6 oocytes, it is 71% and 14.5%, not much difference. 7 to 10 oocytes, 17.8% and 14.5%. Difference, but not much difference. So definitely in poor responder, this study shows that the recombinant FSH and LH has got age over HMG. If you look at the live birth rate, the live birth rate is 12.6% with RFSH and LH combination when there is an extreme poor responder, less than 4 enteral follicle count, whereas it is 3.4 with the HP and HMG. Whereas in higher enteral follicle count group, the difference is not much. Although LH and HMG acts on the same, in HMG the LH activity is derived by SCG only, so it's basically SCG. So the SCG and LH acts on the same receptor, but their pathway are little different. The HMG acts through cyclic AMP pathway and it produces more of progesterone, whereas in recombinant FSH the pathway is different. So there is some difference in the mechanism of action, and which probably is responsible for better result with recombinant FSH and LH combination, which cannot be mimicked with HMG, especially when the patient is extremely poor responder. Now, almost 1 hour is finished. It is 10:28. I think we stop here this discussion, and next discussion will continue next Sunday. Probably next Sunday I am going for some conference. I am not available on next Sunday. So next Sunday I think we'll be meeting. So next Sunday there won't be any discussion, but next Sunday there will be discussion. So we stop this discussion at this point only. If you want to add something, so far whatever has been discussed till now pertaining to this topic, or if you want to discuss in any of your difficult case which you come across while your practice, not related to poor responder, but anything, any difficult case, if you want to discuss, you are most welcome. Dr. Jogesh, you want to say something?
Hello?
Yes, we can hear you.
I'm audible?
Yes, absolutely.
So I have a patient, age is 32 years. She's married since 15 years. The semen analysis shows 100% non-motile sperms. So how could we proceed? And the female part is कि Baba, she is fine, periods are regular. Only the HSG finding is she has one tubal blockage. The rest of things are normal.
Okay. And what is semen count, sperm count?
Semen count 25 millions.
25 million. Okay, so there are two aspects. One is tubal factor, and another is male
female
factor. So
non-motile.
first, let us discuss tubal factor. Now, I always believe that
Mm.
I always explain the patient that two tubes are two sisters. If one
Yes.
has got some problem,
Mm.
another sister is likely to be have some problem.
Yes, sir.
So if one tube is totally blocked, that means that tube is diseased. If
Mm-hmm.
one tube is diseased, another tube is likely to be diseased lesser extent or larger extent.
Okay.
Some way it is going to be affected opposite side.
Affected.
And it is not only the patency of the tube, it is the functionality of the tube also.
Function.
So in
Yes,
such
sir.
patient, unilateral tubal blockage, I do not try much with non-IVF treatment. I always encourage them to go ahead quickly with the
IVF.
IVF. That is one thing.
Okay.
Second thing, coming to a male aspect. Now, this is the husband has got all immotile sperms.
Forms.
That is to be concluded after second 2 or 3 semen analysis. First thing.
It is been
After
confirmed.
confirmed.
Yes.
Now your question is why it is immotile. So we need to investigate further. We need to look into a morphology. We need to look into a DNA fragmentation test, and we need to look into HOS test also. All sperm function tests are required. If all the sperm, and that will give a further idea about the reason. If everything is found normal, so DNA fragmentation is not there, morphology is good, then your question, and if you have ruled out the infection part also, you have treated with the antibiotic also,
Culture
so
is normal.
you have covered almost all aspects.
Yes, sir.
His hormonal analysis, FSH is not raised.
Yes.
The hormonal profile is normal. Now then, you really can't do much in such patient. Then your aim is to what to do if patient wishes to go for A.R.T treatment.
Yes,
then
sir.
you want to select the viable sperms, because non-motile sperm you cannot differentiate which sperm to be selected. So for that, HOS test has been suggested just before the ICSI, and by doing that you can select those sperm. But then I have not done so far in my practice, so for me it is difficult to opine. But then people have done it. They say that it increases the chances of conception. But I always will counsel the patient, if some such semen analysis I come across, I would some additives, antioxidants, antibiotic, I will investigate thoroughly, and still the semen remains the same. I would advise them to try for TISA or probably donor IVF. Donor IVF. Donor sperm IVF.
Fine, sir. One more?
Yes, you want to add something?
Another patient, sir.
Yes, tell me, please.
She is a 40-year female with a history of secondary infertility. It's a second marriage. AMH is very less, 0.6. The ultrasound picture of ovaries, the ovaries are very sleek and small ovaries. She is amenorrheic. Now she is planning for second pregnancy. The husband semen count is normal. The problem is ki Baba, after stimulation of latrose, the endometrium is not responding. We had flushed this patient with PRP, only flushing. Latrose and was not the endometrium did not responded beyond 6 to 7.
Follicle growth was there?
No follicular growth.
Then how do you expect endometrium to grow if there is no follicular growth?
So that is the problem, sir.
So if there is no follicular growth, from where the estrogen will come?
In spite of supporting with estrogen, Proganova, I have started her, still she was not responding. in spite of estrogen, letrose?
Okay, so we can understand there was no letrose did not cause any endometrial proliferation. But
Yes.
Provenova should help in proliferating the endometrium. If the endometrium is still not proliferated with the Provenova, that means basically that patient estrogen receptors are resistant and probably requires repeated priming. So this patient needs higher estrogen exposure for a longer period, probably 15 days, 1 month, 2 months, 3 months, up to 3 months. And whenever she develops endometrium, in the next cycle, you should plan further. Till that, you should not plan anything. We are talking about A.R.T, right? Not normal A.R.T. Yeah. So then and then you should plan.
Estrogen to be continued. What is the
Because
higher?
There is yes, if you have heard my discussion on thin endometrium, there is one very beautiful study. They have studied very hopeless cases of thin endometrium. And what they did, they give a very high dose of estradiol. They are 2 milligram up to 16 milligrams, 6 milligram, 18 milligram. 18 milligrams a day. Dr. Neelam, Mishra, I'm coming to you. Please have little patience, please. So up to 18 milligram per day. So and they give till 3 months. So whenever this endometrium had crossed 8 millimeter, they induced menstruation, and then they started a fresh cycle for transfer. And if the endometrium was not grown, they induced the period and again did the same thing, higher dose of estradiol to keep the serum estradiol level less than 5,000, but more than 1,000, between 1,000 and 5,000 picogram. Their whole idea is to, priming of the endometrial estrogen receptor. So, they said that out of those 100% hopeless cases, almost in 98% they could get the good endometrium and reasonable success rate, I would say. Okay.
Sir, any thing particular regarding the higher dose of estrogen? What about the liver function?
Yes, a very important question you asked. When you are giving very high dose of estradiol, your only worries are two. One, the disturbance in the lipid profile, and second, thromboembolic phenomena. Now, thromboembolic phenomena in Indian scenario little less likely, but definitely lipid profile you have to look into. So if with the higher dose of estradiol, if the patient gets some lipid profile derangement, then patient is encouraged to exercise little more, and this statin can be offered to them temporarily till they are on higher dose. And once they stop taking higher dose, the lipid profile normally returns to normal.
Or any other brand or dose or route?
That we have discussed in thin endometrium. I think you were there or not?
I was not there. I will go through it and then let you know.
Yeah, please go through that.
Yes, sir. Thank you, sir. Thank you for a very nice Sunday.
Thank you. Dr. Neelam?
Yes, Dr. Rajesh, I have few questions. Can I ask you?
Yes, please go ahead.
I just wanted to ask, can we see hyperstimulation in poor responders?
Can we see hyperstimulation in poor responders?
Can we expect that? Because sometimes,
yeah, practically speaking.
Nowadays, what we are getting is 1700-1800 E2 estradiol on day of trigger, and still if we transfer in fresh when we do fresh transfers in patients who we have retrieved only 6 eggs or 7 eggs, still if we are getting hyperstimulation in those patients. So, and like, have you seen such?
No, I don't, because I give gonadotropin very calculatively. So there are various theories put forward. Still, the only reliable theory of developing ovarian hyperstimulation syndrome is through VGF
Yeah.
receptors, right? And
Yeah.
the estradiol has got direct effect on increasing the VGAF.
Yeah.
So if you bombard with too much of the gonadotropin,
We don't cross 300. Like, because I use recombinant FSH, so mixing with HMG also, we never cross 300.
So if one mechanism, suppose if you get the OHS, I have not got, but suppose if
And
you got
the patient
OHS,
gives history of similar episode in last pregnancy. Like she says, ki I always get hyperstimulation when I'm done.
So for the possible explanation is one, higher uses of gonadotropin. Two,
Yeah.
The receptor cross reactivity. If the patient is hypothyroid, sometimes there is a cross reactivity of gonadotropin with those receptors, and because of that, in spite of stopping gonadotropin, it keeps getting stimulated. This is another explanation put forward. Third explanation: some additional source of SCG somewhere in the body, some SCG secreting tumor, or maybe missed pregnancy. So these are the possible explanation, but really difficult answer to this question. Normally, the OHSS is directly proportional to the number of the oocytes retrieved or peak E2 level. These are the normal two criteria we
no, but I have two cases recently, but both of them had very low E2, like normal E2, 1800, 8 oocytes retrieved. And but first one patient, she gave history that I had similar episode in last pregnancy. Only
one more explanation, madam, maybe the SCG component of the HMG has got higher,
potency. Yeah, it's staying for longer duration. Maybe use the thing that. Yeah, because ovaries are still very big, and that way, like it looks like they have got big follicles still. It's not hemorrhagic thing. And one more question I just wanted to ask: how do you transfer in FAT cycle when you ovulate the patient and then prepare the endometrium? Because sometimes the patient doesn't come out with the artificial estrogens. So sometimes we give them some HMGs or something to make them ovulate and then do their FAT cycles. So do you count if you're doing day 5 transfer, like blastocyst transfer? Do you give 5 days of progesterone taking from day of trigger, or 2 days after that, like we do for OPU, and then we count the days of progesterone?
Okay.
Do you get my question?
I understand. See, basically, you have to understand.
Yeah.
That there are two things. One is embryonic age, and another is age. The embryonic age.
Yeah. Sorry, can't hear you.
Time where you're done insemination. From that point of time.
Sorry, I can't hear you. Voice is dropping.
So, from my side, hello, can you hear me?
Hello, yeah. No.
Yeah, can you hear me, Dr. Neelam?
Yeah, now I can hear you clearly. Yeah,
okay. So we were discussing the embryonic age should be counted from the time of insemination, and endometrial age should be counted from the that first exposure of progesterone in artificial cycle, and ovulation in other cycle. Right. So this probably will give you the answer.
Yeah.
So when you are stimulating the ovary for preparing the endometrium, you should count endometrial age from the ovulation, not before that.
Okay.
And if the ovulation has not been documented And if the only LH surge has been documented, 24 hours after the LH surge.
Okay. Fine.
Okay. Yeah.
Okay. Thank you very much. Thank you. It was very nice.
Thank you. Jigyasa wanted to say something. Dr. Jigyasa want to say that I have a patient of 37 years with single ovary. The AMH is 1.2, expected poor responder. FSH or HMG, what should be started for adequate response? Dr. Jigyasa, this answer you will get in our subsequent lecture. So please pardon me till that. How to stimulate POSEIDON group 1, how to stimulate POSEIDON group 2, how to stimulate POSEIDON 3, and this is POSEIDON group 4. So till that, if it is not urgent, please pardon me, and if it is urgent, call me on my personal number. After this is over, I will guide you further. The another question asked, does using SCG instead of HMG after 10 millimeter follicle affect the oocyte quality? Are you talking? See, suppose if you are using this for non-ART cycle, means non-IVF cycle, then it doesn't matter. It is the effect same. I have done quite a few times to cross 10, not 10 millimeter, I consider 12 millimeter. Follicle is crossed 12 millimeter. I use microdose SCG, small dose of SCG instead of gonadotropin to cut down the cost, and the follicles keep growing. And then I will give trigger with the SCG only, and then it goes like that. But if it is ART cycles, IVF cycle, probably I would not take such risk if I am planning for fresh transfer. For the one reason, the SCG has got long half-life, so that if you have given SCG during follicular phase also, the effect gets accumulated, and probably patient may, if the follicle is more, number of the follicle return more, then probably she may develop OHS. That's one thing. And second thing, if you are using SCG, it regresses the intermediate and small follicles. If you have started using from quite early part, mid follicular phase, where actually some of the follicles which have got some potential of developing, having higher FSH threshold, and they are little late riser, they get regressed if you use SCG. So this is a second apprehension of using SCG in a mid follicular phase. Little late follicular phase, definitely SCG can be used. On the contrary, if you use SCG in late follicular phase, it will suppress or it will regress the smaller follicle, and the results will be better. Any other question, or you want to add something, anybody? Because I cannot see any raised hand or any, I cannot see any update, any chat. Dr. Jogesh. Yes, Dr. Jogesh.
Sir, is there any specific way of doing an AMH? Some microbiologist was saying कि बाबा, if you have a tight band over the blood collecting hand, it affects. Does it?
So far as per my knowledge.
Hello?
So far as per my knowledge, can you hear me?
Yes, sir.
As per my knowledge, the AMH, there are certain precautions to be taken when you are collecting a blood sample for AMH. Number one, Uh, it should not be collected in the EDTable.
Okay.
One, two. It should be immediately. Serum should be separated. Serum should be separated immediately. It should not lie the whole blood sample like that, and then you send to the laboratory. The serum should be separated immediately. That is second thing.
Okay.
And third thing, while in transit, preferably the temperature should be maintained. It should not be heated, but then it is beyond our control. So these are and it should be processed as fast as possible. So these are the only precaution in collection and transporting the sample. Then rest comes the technical aspect, which method is better for AMH. So this is a CLIA method. CLIA method is better. So, but then I have not gone into the depth. But I have not never heard or never read anywhere that if you apply tight band, then the AMH results get affected. I am not aware about it. Your friend may be true, but I am not. I am ignorant about that.
Which method?
CLIA, CLIA method.
Okay, fine. Thank you, sir.
Yeah.
And how long you are there for the personal conversation?
Till any query is there, I mean, next half an hour, max half an hour.
Sir,
I think I don't. Only Dr. Neelam Mishra has got one more question. After that, I'm coming to you.
Yeah. Yes, sir.
Yeah.
You have discussed like thin endometrium and all.
Dr. Neelam,
Yeah.
now I can hear you.
Yeah. How can we listen to your older talks you had held, like thin endometrium topic? How can we hear them?
That I have shared the link. I think I have uploaded all my talks on, except one talk. All talks have been uploaded on YouTube.
On YouTube.
YouTube. Doctor, you type, just search Dr. Rajesh Koradia. Hello, Dr. Neelam, can you hear me? Hello, Dr. Neelam, can you hear me? हेलो हेलो
रूटीन चेकअप के लिए आना, उनके हस्बैंड को भी बता दिया. ठीक.
डॉक्टर नीलम, any other question for?
हाँ, फाइल भेजो. हाँ.
Dr. Neelam, any other question? Dr. Jogesh, I'm coming to you. Yes, tell me.
Yeah. Sir, I have a patient. Her HSG findings were one-sided tubal blockage at the cornual end. Hello?
Yes, I can hear you.
The laparoscopic findings were the uterus was deviated towards that side. Because of that shortening of the ligament, the tubes get conked and it was obliterated. So the laparoscopic person did the release of that from that side and tightening and centralizing the uterus. So what could be, there was no endometriosis. The only positive finding was she had bulky ovaries. Rest of the things were normal. So what should we investigate for that deviation of uterus?
If the uterus is freely mobile, so now our apprehension is deep pelvic endometriosis is there or not. So if the mobility is restricted, if your internal examination and transvaginal probe manipulation is not tender, then possibility of the deep pelvic endometriosis is not there. Second possibility is chronic PID leading to a fibrosis of the deep pelvic cellular tissue. Another apprehension. Now, if that is there, you need to give one good course of antibiotic because nowadays lot of people have started discussing about the role of endometrial biome on the endometrial receptivity. So any information regarding the PID should be taken care and it should be treated adequately. Too much exposure of the antibiotic is to be avoided because it changes the vaginal flora. So that is also not good. So again, judiciously you have to use antibiotic, not empirical use of antibiotic. That is one thing. Now coming to corneal blocks. The corneal blocks are relatively more friendly as far as the results are concerned. And you can try hysteroscopic cannulation in that, and almost you are successful in as far as the negotiation of the corneal this thing blockage is concerned. But the only unfortunate part is the 50% of the time within 1 year it is again reblocked. That is, and those who within 1 year approximately 20% of those patients is conceived.
Should conceive.
Are not able to conceive, and again we have to go for A.R.T.
Okay.
Okay. The another question, the name is not written. Does using SCG, okay, that has been discussed. Any special tips for OPU when only 1 or 2 follicles are present? Okay. So when only 1 or 2 follicles are present, obviously you are very much anxious about not missing those follicles. What are the options with you? You go conventional way. 2, you use little higher pressure suction. And 3, you use double lumen ohm aspiration set so that you can do the flushing of the follicle. And 4th, you do curettage of the follicle while ovum pickup. Now, as far as the double lumen needle and flushing of the follicles are, that is, as far as it is concerned, I have never done it. I use only single lumen. And so far in my experience, I always correlate the estimate put before aspiration is started. Normally, I give, whenever I am updating to my embryologist, I always tell that I am expecting this many number of the oocytes. And normally, in 98% of the time, it is correlated as well. So, there is no need to use double lumen and needle and flushing of the follicle. That is one thing. Second thing, definitely I would wish to have little higher pressure. Normally I keep 100 between 110 and 20. In this patient, when the follicles are less, I would keep little higher 130, 140. That is one thing. And I will do simultaneously curating of the follicular wall when the aspiration suction is going on. These are the only 2 things which I think I would suggest you. If anybody else has got anything, any suggestion, you are most welcome to update. Dr. Jigyasa wanted to ask, should Jigyas, I have already if you look at, she is asking how to raise hand. Already, if you had carefully read, every time the instruction is written, on the extremely right, there are 3 dots. You have to touch that dots. That is a more. So in more, if you touch this more, the option comes. Then there is a option of raising hand. So you can raise the hand by that. So immediately it will notify to me, and I will come to know that you want to add something or you want to ask something. So your question is, should hydrosalpinx be treated by salpingectomy or clipping or left as such, both in case of FET and fresh transfer. Now, the answer to this question, what is, first of all, we have to understand what is the reason, why we want to separate the hydrosalpinx from the uterus, because we do not want embryotoxic fluid to enter into the uterine cavity. So if you have frozen embryos with you, adequate number of frozen embryos with you, more than 12 embryos with you, for example, and now you came to know that there is a hydrosalpinx and you need to treat. So in this case, I would prefer just delinking or clipping. That's it. But if it is done before the stimulation, then I would prefer to do a salpingectomy. Why? Because if you are delinking tube from the uterus, you can very well prevent the embryotoxic fluid to enter into the endometrial cavity. But still, the structure containing potentially harmful cytokines, I do not want to keep in the abdominal cavity, in the vicinity of the uterus and ovaries. So I would like to do salpingectomy and take out the affected tube, because it can affect the oocyte quality also, theoretically, logically. So if the stimulation is not done yet, I would remove the salpingectomy. Otherwise, if I have got frozen embryo adequate with me, then I would do the clipping of the tube. That is my answer. But only thing, while doing salpingectomy, you should try to remain as close to tube as possible, so that you do not want to disturb the vascular and anastomosis between ovarian vessels and uterine origin vessels. There is nobody has raised any hand or no question. It is 11 o'clock, 3 minutes. If there is no any extra other question, can I conclude?
Yes.
Sorry,
I have unmuted you all. So if there is no question, can I conclude?
Yes, sir.
Yes, sir.
Okay. So we will be meeting again next Sunday. Next Sunday, I am going for some conference. I have to present some study, and next again we'll be meeting and continuing with the poor responder. Okay. Okay. Thank you so much for being with us.
Thank you, sir.
Thank you, sir.
Okay. Thank you so much.
गाड़ी फिरा के